Hello, everyone. Hi, my name is Dr. Amar, and I'm going to be doing this lecture on immunodeficiency. And I apologize in advance. My Arabic is terrible. Growing up, the only Arabic I knew was when my teacher would be yelling at me, calling me a batikha, or well, I don't know. So, so I'm sorry about that, but I'm going to go slowly. So hopefully it's easier to understand. So immunodeficiency means problems that happen within the immune system. So you've learned about immunology, how it's supposed to function. Now let's talk about certain diseases where the immune system does not work properly. This is a little chart. I liked it. I got it off of Robbins. We're going to refer to it a few times, but basically, this is kind of where a lot of the syndromes are, and we'll go over it slowly. So there's many types of immunodeficiency. There's primary and secondary. Primary means it usually means something genetic, right? Something genetically wrong with you that you inherited that went incorrectly. Now, secondary is your immune system, so that caused your immune system to be depressed. Now, a secondary immunodeficiency is something that happened to you or something that you did that also caused your immune system to be depressed. For example, somebody has cancer, right? That can destroy their immune system. If you're on chemotherapy for your cancer, obviously then your immune system is not working. Somebody who's got chronic disease, somebody who's malnourished, uh, drug abuse can destroy your immune system. I've seen alcoholics with terrible immune system. I work as an emergency medicine physician, so it's mainly I see a lot of the secondary causes. The primary causes are usually picked up by your pediatricians, and they usually start, in childhood, and we'll kind of go over that. Okay, but and then also a very important secondary cause is HIV and AIDS. Uncontrolled HIV leads to AIDS, which obviously is a big problem worldwide. But we're going to primarily focus on primary immunodeficiencies, so genetic immunodeficiencies. So they can be kind of divided into two parts: cell mediated, which is your T cells, and humoral mediated, which is your B cells. You'll hear this commonly referred to as cell mediated immunity, humoral mediated immunity. You need to know cell mediated T cells, humoral B cells. Um, that's that. So primary immunodeficiencies, they start at, usually you start to see them at 6 months to 2 years old. Um, at 6 months is a very common time, and if you know why, it's because the first 6 months of your life, when the mother especially is breastfeeding the baby, her immunoglobulins get transferred to the baby, and therefore the baby, has that protection. But after 6 months, the baby is supposed to start making its own immunoglobulins, and when it doesn't, or there's an issue with the pathway, um, then that's when a lot of doctors will go, "Ooh, something's wrong." Okay, so that's when they start to present 6 months to 2 years of age. A lot of them will be at 6 months. Some will be in early childhood as well, depending on the type. So let's start with SCID, SCID, severe combined immunodeficiency. This is the worst one. Okay, when you hear about bubble babies, which I'll show you in a few slides here, they have to live in a bubble. All right. Thankfully, this disease has a cure now, but back in the day, everybody who got this died before the age of 1. Basically, you don't have an immune system, right? Um, your immune system is completely gone. You don't, and there's many different subtypes of this. There's one where it just affects mainly your B cells, mainly your T cells, but for your purposes, it affects B and T cells, and your immune system is completely destroyed. Okay, so etiologies. What causes this? A few things: cytokine receptor defects. So basically, all the interleukins that are produced, um, there's the receptors for those interleukins are defective. Okay, interleukin 7 is probably the most important cytokine because it stimulates survival and expansion of B cells and T cells, and it's produced by a CD4 T cell. So a CD4 T cell, as I showed in the chart on the top, produce uses interleukin 7 to help other CD8 cells and makes the B cells more mature, right? But in all honesty, all the interleukins 2, 4, 7, 9, 15, they're all affected, okay? And cytokine receptor defects are usually X linked, unfortunately, so mainly presents in men, but I don't think you really have to know that. Adenosine deaminase deficiency, that's a very common cause of SCID as well. Basically, you have high levels of adenosine and deoxyadenosine, and this inhibits DNA synthesis and therefore is toxic to lymphocytes. Okay. If you remember basic genetics, you know that that's true. So, adenosine deaminase deficiency, you get high levels of intracellular adenosine, deoxyadenosine, and you can't produce DNA, and therefore your lymphocyte dies. And then MHC class 2 deficiency. Remember, CD4 cells present, MHC class 2 molecules present antigens to helper CD4 cells. Okay. So the way I remember CD class 2 or CD class 1, this is an easy mnemonic, is let's say a CD8 cells, they bind MHC class 1. CD4 cells bind MHC class 2. 4 times 2 equals 8. 8 times 2 equals 1. I call it the rule of 8. So if you think CD4 cells, well, if it follows the rule of 8, then CD4 binds to MHC class 2 because 4 times 2 equals 8. I don't know if that's helpful. Some of you might find it helpful. But regardless, all three of these result in SCID. Um, and you're susceptible to everything. Okay, the fungus and viruses are usually fought by your T cells. Bacteria and protozoal infections are fought by B cells, although some intracellular bacterial infections are also fought by B cells. So at you start seeing this, pretty early on. Um, and for example, if you look in the mouth, there's a picture of a mouth here that has thrush, which is a candida infection, a yeast infection. That's not very common, right? Obviously, you shouldn't be seeing that right away. You get tons of diaper rashes because of fungal infections, which is shown in the top right photo. And you get a lot of failure to thrive. The babies just are tiny and just are not meeting their growth requirements, which is that photo of that smaller baby on the bottom. Um, uh, and also, this you get a lot of opportunistic infections, right? Obviously, because your own immune system is down. And again, this is something, in this situation, I would stay away from live vaccine like the polio vaccine that you eat. The treatment, isolation, put them in a bubble, and a hematopoietic stem cell transplant. Why? Because obviously that goes, to the marrow, produces blood cells that you could not produce before. Now, fortunately, most of the time, this disease has been treated really nicely. This is photos from the 50s, where one of the last, I think it was 50s, 60s. Don't quote me on that, but yeah, the last of the bubble babies. DeGeorge syndrome. Now, this is a great syndrome that shows up on test questions because it tests your knowledge of embryology. Ew, I don't like embryology, but it is what it is. So, DeGeorge syndrome. Basically, what you got to remember is this is one of those things where you have a failure of the third and fourth pharyngeal pouches. So, if you think back to embryology, don't send me any questions on embryology. I don't remember much. But third and fourth pharyngeal pouch, they make a lot of things. And it's due to the 22q11 microdeletion. Just make a note card, memorize that. 22q11 microdeletion, which results in the developmental failure of the third and fourth pharyngeal pouches. Um, so therefore, what happens is what the reason this third and fourth, the third pouch leads to the development of the thymus. The thymus is where T for thymus, T for T cells, right? Thymus is where T cells mature. They're formed in the bone. The immature T cells are formed in the bone marrow. They go to the thymus and they mature. So if you don't have a thymus, or it's a very underdeveloped thymus, chances are you're not going to have very good T cells, right? And remember, we talked about T cells equal fungal and viral infections. A lot of fungal infections, a lot of viral infections. You're also maybe get some protozoal infections and some intracellular bacterial infections, but mainly T cell equals fungal and viral. Um, so the patients usually present again with T cell deficiency because lack of thymus, right? And then hypocalcemia because the parathyroids, right? The parathyroids making um, uh, PTH, parathyroid hormone, which increases calcium. Okay. Another way to remember this is if you know anybody who's got a thyroid surgery, right, where they remove the thyroid, the parathyroids are tiny and they're inside the thyroid. And a lot of times we accidentally remove the parathyroids. They're calcium falls, and we have to give those people oral calcium. I see that all the time, right? So lack of parathyroids, low calcium. Okay, and then abnormalities of the heart, great vessels, and face. This is an embryological phenomena, not just an immune phenomena, but an embryological phenomena. So these kids are going to have different faces. They're going to have cleft lips. Their nose brow ridge is going to be abnormal. I'd say just look up a photo online. It's hard for me to describe it. They're going to have they could have cognitive delay, learning difficulties, and the cyanosis. I believe that's referring to the abnormalities of the heart and great vessels in that photo as well. Okay, so embryological plus immunodeficiency. So unfortunately, these are not. This is something a lot of pediatricians will have to deal with. X-linked A gamma globulinemia. Okay, so this disease was properly named. Okay, if you ever discover a disease, please name it so everybody can easily remember it. Or if you're gonna name it after somebody you don't like, right? But if you're gonna name a disease, please name it so it's as easy to remember as this. X-linked A gamma globulinemia. X-linked, so we know it's mostly in males, right? A gamma means nothing, no immunoglobulins whatsoever. In anemia meaning in your blood. So X-linked A gamma globulinemia. Okay, so complete lack of immunoglobulin due to disordered B cell maturation. Naive B cells cannot mature to plasma cells. Okay, um, so this is because of the BTK. Okay, so an Bruton tyrosine kinase, it's a signaling molecule, meaning the pre-B cell receptors um, cannot signal the cell to go down the maturation pathway. So your B cells are just messed up. You don't have uh, your light chains for your B cells are just not produced. All right, and you can see I xed out the light chain in the diagram here. It's one in X, so it's saying somewhat common, 1 in 100,000. Um, and since it's X-linked agamma-globulinemia, there's a few things that can happen. Okay, since you have no immunoglobulin, let's kind of go over. This is a great time to memorize what the immunoglobulins do, right? So you don't have IgG, right? So you can't opsonize bacteria. So that's why you get recurrent bacterial infections. You don't have IgA. IgA mucosa, right? Anytime you think IgA, you think open your mouth, mucosa, right? And what's the what organs have mucosa, right? Your oral cavity, obviously your mouth, the intestinal lining, the stomach, the small intestine, large intestine, that all has mucosa in it. So you're going to get enterovirus. Entero means, in the gut. So you're going to get a lot of gut viruses. You're going to get a lot of diarrhea. Giardia, that's unfortunately a disease that you can get easily if you drink like contaminated water or other issues. So again, you don't have IgA, so you're easily going to get a gut infection of IgA. So since these people cannot produce um, any immunoglobulins, the treatment is intravenous immunoglobulin. So you actually take immunoglobulin from donors and you infuse them every so often through an IV, and they come every, I don't know how often they do, but they come to the hospital, they sit down, they get their infusion, and they go home, and it's like a dialysis patient where they just keep coming back. Um, and obviously, since their gut is messed up, they have bad gut. Um, you don't give them a polio vaccine, right? Their IgA is messed up. Don't give them a polio vaccine. They might accidentally um, get polio, right? And this presents after 6 months of life because why we talked about it because the first 6 months of life, you get your immunoglobulins from your mother. Okay. CVID, common variable immunodeficiency. Okay, this is common variable, commonly affects. So the way I remember this is it's common, so it commonly affects both sexes, so male and females. Okay, it presents in childhood, not as a baby, because you do have some immunoglobulins. They're just low, so it's not like the previous one where it was A gamma. No, this is just low. Okay, common variable, just low. Low immunoglobulins are B cell or helper T cell defects. And again, just as before, you have low immunoglobulins, so bacteria, enterovirus, and Giardia infections. and this one a little bit later in childhood. Okay, um, uh, and increased risk for autoimmune diseases and lymphoma. All right, that makes sense because a lot of these autoimmune disorders are linked with other diseases as well that fall into the same category. This disease is caused by multiple causes. Let me see if I can take you back to the, like you can see CVID here at the bottom. It's got multiple issues that um, can lead to it. Okay, but basically, you're just low in everything. Um, Sorry, give me 1 second. I'm gonna go back here. All right. Um, and the one thing that they love to test is autoimmune diseases that go with CVID, so rheumatoid arthritis, pernicious anemia. That's basically anemia due to lack of B12. Hemolytic anemia, basically you're anemic because something is attacking your RBCs, and that kind of goes hand in hand. CVID also patients present with recurrent sinopulmonary infections in childhood and adolescence, and we talked about this risk of lymphoid malignancy. The sinopulmonary infections, obviously, when you don't have immunoglobulin, and especially A, you're going to get a lot of infections in your nose, your mouth. So think of like people who get recurrent sinus infections. Okay, and I put this little child photo up so it's kind of the one you get in childhood and adolescence, not as a baby. All right, IgA deficiency. This is everybody has it. You have it, your mom has it, Ahmed's mom has it. Everybody has this. Okay, it's the one of the most common ones that you'll see. I never actually diagnose people, but think of this IgA, think of it as like, your aunt who's always got a sinus infection or who always has a runny nose. Chances are she's got IgA. So again, my thing is say IgA, mucosa. Gut, you get diarrhea. It's associated with celiac disease. That's something they like to test. And obviously you're going to get sinopulmonary infections because again, there's mucosa inside. Okay? But it's the most common immunoglobulin deficiency. Hyper IgM syndrome. So this is characterized by what it sounds like elevated IgM. I put this chart up so you can kind of see this. Um, and let's actually talk about, and I think Dr. Sattar does a good job. So I'm going to summarize kind of what he said about how, in order to understand the syndrome, you got to understand how B cells are activated. The first way the B cells are activated is an antigen comes in, binds the IgM receptor on the naive B cell, and turns it into a mature B cell that produces IgM. See on this chart, it's the bottom left corner here. It says IgM mature B cells. Okay, so great. IgM, easy. It turns into IgM by binding an antigen on its IgM receptor. But the second method of B cells activated is by this whole mess. Okay, it requires two stimuluses. Okay, so the first stimulus, that what happens is the naive B cell takes in the antigen and presents it as an MHC2 to a CD4 helper T cell, like we talked about before, which has a TCR receptor. That's the first stimulus. Then the naive B cell presents a CD40 ligand, which binds to the CD4 helper T cell. That's the second stimulus. All right. And the second stimulus we're going to come back to, that's the important one. Both of these stimuluses combine, okay, and they produce and they cause the CD4 helper T cell to produce interleukin 4, interleukin 5, which then converts the naive B cell into a mature B cell that produces either IgA, IgG, or IgE. Okay. Now, this is when it comes to hyper IgM syndrome, this is the problem. The second signal where the CD40 receptor binds the CD40 ligand on the naive B cell. That doesn't happen because one of those two is messed up. And therefore, you can't make IgA, you can't make IgG, you can't make IgE. But guess what? You can still make IgM because that has nothing to do with CD40. And that's why it's called hyper IgM syndrome. I hope that makes sense. Go back and reread these slides a few times, okay? And so, since again, you can't make IgG, so and IgG is an opsonin, so you get pussy pyogenic infections. Can't make IgA, open your mouth, mucosa. So you're gonna get sinopulmonary infections throughout your lungs and throughout your mouth. Okay. Honestly, I don't even remember what IgE does. Somebody Google it, look it up. I am not an immunologist, but this is, I think, the important part and how you're going to remember hyper IgM syndrome. Okay. Um, and if another great test question they're always going to ask you is, what cytokines aren't produced in hyper IgM syndrome? Well, if you're like, well, what the CD4 helper T cell? Well, it produces interleukin 4, it produces interleukin 5. That's how it makes these. So memorize interleukin 4 and interleukin 5. I would just redraw this chart a few times. I think it's just a fun thing, not a fun thing, but a necessary thing to draw. Okay. Um, all right. Carrying on with primary immunodeficiencies, Wiskott-Aldrich syndrome. Again, this is something you just got to memorize. Okay, thrombocytopenia. You get petechiae, little dots. The way I and this is and then eczema, where you get a little skin rash and recurrent infections, humoral and cellular. So humoral is T cell, cellular is B cell immunity. Okay, and this has to do with the X-linked mutation in WASP gene. Again, something dumb you just have to memorize. But WASP, thankfully, was got Aldrich syndrome protein gene, right? Hopefully, you don't mess that up. Um, let's just touch on these signs real quick. Thrombocytopenia means low platelets, so you're going to get little blebs of bleeding, and usually they're non-blanching. And when we get to hematopoietic disorders, it's going to come up, and you're going to go over those and all the causes for thrombocytopenia. And that's something that's very clinically relevant, but just categorize this in your back of your head as being one of the causes, okay? And then primary immunodeficiencies when it comes to complement. Okay, so there's the last one that we're going to go over for primary. So C5 through C9 complement deficiencies and C1 inhibitor deficiency. So C5 through C9, you have increased risk for Neisseria infections. Remember, this makes the membrane attack complex. Okay, the way I remember this is only compliment your wife or you will get gonorrhea and you will go crazy. Neisseria gonorrhea and Neisseria meningitidis, which gives you meningitis. So only compliment your wife or you're going to get gonorrhea and go crazy. I know it's a bad mnemonic, but you know what? I remember it from medical school, so hopefully it helps you too. Okay. And then C1 esterase deficiency. This one is near and dear to my heart. I do see this from time to time in the hospital. This comes in a lot of times as an emergency. People will have periorbital edema, lips, big tongue, so they have a potential for an airway obstruction. That obviously can cause you to die as well because you have to secure that airway. You're going to learn in pharmacology about uh, ACE inhibitors causing angioedema as well, which is swelling around the lips and the tongue. So ACE inhibitors or C1 ester inhibitor deficiencies, those both cause the big tongue, big lips, and sometimes the eyes. Usually, those people will have it's easy to diagnose because you say, hey, are you on an ACE inhibitor medication? If not, then who are you? What else is going on? And you having an allergic reaction? Or maybe have you had this in childhood? Okay, maybe it's a C1 inhibitor deficiency. Remember, complement deficient. This is an inhibitor deficiency one, so that means the C1 is super active, and the inhibitor is not there to turn off the C1. Okay. All right, guys, and then lastly, I know that Dr. Sattar and Pathoma doesn't really go into secondary immunodeficiencies too much. You will probably cover HIV and AIDS during your pharmacology lectures, but remember, just want you to know that secondary causes HIV, human immunodeficiency virus, it causes a depletion of CD4 helper T cells, which, if you've been paying attention so far, is involved in B cell and T cell maturation, right? Your radiation, chemotherapy, decreasing bone marrow, so your stem cells are down, involvement of bone marrow by cancer. So things actually can go to the bone marrow and destroy it, right? Um, Protein, calorie malnutrition, removal of spleen. Spleen is where a lot of the macrophages hang out. They phagocytose, they present, um, antigens. So these are other things that you have to know, as a physician. Okay. All right, guys. I hope that was helpful. Please always give me feedback. Please message me with any questions you have. And one thing I'll say is, as doctors, you need to know a lot about these syndromes just because, not because, you will diagnose it necessarily. Hopefully, unless you're a pediatrician or a neonatal, even a neonatologist won't. But if you're anybody else, you should at least recognize what they are, recognize how they maybe needed to be treated differently. And when your immune system is depressed, you should always, anytime someone comes to the hospital and says, "Hey, I have an immunodeficiency, I have HIV, or I'm on chemotherapy," my red flags go up. I'm more worried about that person because they could easily get an infection that can kill them. So even if they have like a little bit of a fever, but they're immunocompromised, I might do a much larger workup, check for more X-rays, more labs than someone, let's say, the same age who doesn't have an immunodeficiency. Okay. All right, guys. Thank you.